just because you have hydronephrosis doesn't mean that a surgical intervention needs to be done, okay? Because not all patients with hydronephrosis will need surgery. So what are the causes of hydronephrosis? Well, one in children, one is where the ureter meets the renal pelvis right here. It's narrowed. We'll use blue for this. If it's narrowed. And so when it gets narrowed, then urine can't travel past here fast enough from the rate of production of the urine from the kidney, and so you end up with a dilated collecting system or renal pelvis. And the back pressure, if it's high enough, it will start to destroy the kidney. And then they'll slowly drip the contrast down. And then basically, once the bladder fills up, the patient's going to urinate. If it's a child, the child will then urinate spontaneously. If it's an adult, then the adult will urinate on his or her own.
We gon' do it like it's priceless. Take it to the moon. Priceless. One day will be soon. Like it's priceless.
It's another episode with Dr. Pham. D-Talk with Dr. Pham. So I'm going to start off this episode by kind of showing you this. So this is for all you guys out here or out there. If you're like this and you want to become this, and for those who dare to go even further, if you want to become like this, you know who you call. 713-366-7831. So anyways, all joking aside, welcome to another episode of D-Talk with Dr. Pham. So today I'm going to talk about something called hydronephrosis. So I've been getting a lot of messages asking to discuss what exactly is hydronephrosis. And so I brought my little handy drawing pad right here, so it'll make a whole lot more sense. But before you can kind of understand what hydronephrosis is, let's just go through basic anatomy first. So the kidney kind of looks something like this. And so that's your right kidney. This is now your left kidney. And then basically it will insert into the bladder. And whether you're male or female, it's the same, the way the urination system works. And that's your urethra. And if you're a male, then the urethra will be just longer. And then this is your brain. And then this is your spinal cord. So let's use yellow for urine. So basically, well, let's use red first. So basically, blood will get pumped from the heart and gets filtered in the kidney. So think of it like a Brita filter. And then basically, the kidney will then filter out excess water and fluid, electrolytes, and all of that. It's one of the main organs of keeping your body in hemostasis. Now, once the kidney filters the blood, it's going to make urine. And so urine then now is going to go down into the bladder. So typically before you're potty trained, then the bladder fills up to about 30 cc or so in a 1-2 month old. And then it'll send a signal back to the spine, which will then send a signal back to the bladder and also a signal to the urethra, or what I call the bladder neck, to basically contract. And the bladder neck will open first and then contract. And then once you contract, then urine will then leave. And then when the bladder contracts, the bladder has kind of 3 muscle layer. And what the bladder is going to do is that it's going to clamp on the ureter so that urine can't go back up, so that it only has one way to go. Okay. So that's normal anatomy. Now that we've gone through normal anatomy, then let's talk about hydronephrosis. So with hydronephrosis, this is your left kidney, and then this is the ureter, which is the tube that connects the kidney to the bladder. In hydronephrosis, it means exactly that. Hydro just means water, and nephrosis just means swollen kidney. So this part right here is what we call the renal pelvis. And so hydronephrosis is when you get dilation that is more pronounced than what is considered normal. And what is considered normal, that's very debatable. But for me, normal means I don't see any sort of swelling on ultrasound because of the way the ultrasound works. Basically, if you don't have hydronephrosis, then you're not going to see kind of this big black area. And so now the question is, what do you actually do with hydronephrosis, and what is the clinical consequences that comes with it? Because just because you have hydronephrosis doesn't mean that a surgical intervention needs to be done. Okay, because not all patients with hydronephrosis will need surgery. So, what are the causes of hydronephrosis? Well, one in children, one is where the ureter meets the renal pelvis right here, it's narrowed. We'll use blue for this. If it's narrowed. And so when it gets narrowed, then urine can't travel past here fast enough from the rate of production of the urine from the kidney. And so you end up with a dilated collecting system or renal pelvis. And the back pressure, if it's high enough, it will start to destroy the kidney. And so in children, it's very important that if they have hydronephrosis, you need to follow them with ultrasound. Now, how often do you do the ultrasound? That really just depends on the patient and how bad the hydronephrosis is in the first place. Now, outside of birth, there's really no real grading system. Unlike when the baby's in the mother's womb, they have what we call Society of Fetal Urology grading system. Once you're outside, there is no more grading system. Uh, and so when you get the read, sometime it'll say mild hydronephrosis, moderate, and severe. Well, to me, that doesn't mean anything because there's no numbers. Like, what does moderate mean? Because to one person, moderate may mean something else, and to another one, moderate may mean something else. So even to this day, these ultrasound readings, the most important thing is to really measure how dilated it is. But just to tell you, it takes an act of God for all the radiologists to even agree to that. And so a lot of times when we send patients for ultrasound, we tell the patient as well as we specify on the order form to please measure the dilation because that's what's more important. Now, what is another cause of reflux? I'm sorry, hydronephrosis. Another cause would be reflux. So you remember previously I showed you guys how urination works. And so what happened is if the ureter is not buried deep enough into the muscle, then like something like this, then you're not going to get good coaptation. So when the bladder contract, it's not going to press against the ureter. And so actually going to get urine that will reflux back up to the kidney. And that will also give you a similar image when you have obstruction at the where the ureter and the uh, renal pelvis meet, what we call the ureteral pelvic junction. Now, as you get older, then that may become a little bit more obvious because you can see dilated ureter, but sometimes you don't see dilated ureter. All you really see is just hydronephrosis. And so that's why there are what I call confirmation tests. These tests are a little bit more invasive, but they will confirm whether you do have reflux or not. So I use ultrasound, at least for me, anyways, to follow. I think it's a good tool to follow and a good tool to justify doing a more expensive and a little bit more invasive test. And what do I mean by that? Well, if I'm worried about this child, what I usually do is I'll order something called a voiding cystourethrogram. And what they would do is the pediatric radiologist would do this. They would put a catheter in the patient, whether it's male or female, and then usually like a feeding tube, and then they'll slowly drip the contrast down. And then basically, once the bladder fills up, the patient's going to urinate. If it's a child, the child will then urinate spontaneously. If it's an adult, then the adult will urinate on his or her own. But what it is when they urinate, they're going to take a few x ray pictures to see if they see contrast go back up the kidney. And that's how you can confirm or exclude vesicoureteral reflux. The other test I do is something called a renal scan, specifically a MAG 3 renal scan, because they have different types of renal scan. Renal scan is just a catch-all term, but depending on what you're looking for. In this case, I would order a MAG 3 scan. And what the MAG 3 scan does is they put a special tracer that has very low, very, very, very low radioactive substances, much safer than uh, CAT scan in terms of radiation. And so, what that dye is going to do is going to get picked up by the kidney, and basically at around 20 minutes, just to speed up the test, or else you'll be there all day. They're going to give some Lasix, and then they're going to look at the drainage pattern, and the drainage pattern will be referred to as something as T1 half. And if you're 10 minutes or below, meaning the tracer gets out, then that's considered normal. If you're around above 10 to 15, maybe 20, that's indeterminate. So, with that, you go on symptoms if the patient's able to tell you if they have symptoms. So, what I mean by that is if you have a 5 year old, then the 5 year old can tell you, hey, my back hurts when I drink a lot of fluid. And the reason why is because when you drink a lot of fluid, the kidney is going to try to filter all that water out. And so, if this is a fixed obstruction, such as ureteral pelvic obstruction, then the water is going to back pressure and push on the kidney. And then that's how they present with pain. Now, in children, you have to be very careful because, just the way the body works, if I close my eyes and someone touch my fingers, I can tell you exactly which finger you touch, like, you touch my thumb, whatnot. The problem is once you get inside the organs, the brain really can't separate pain from one area to the other. And what do I mean by that? If you have pain in your, let's say, right side, what you don't know is it constipation that's causing this pain? Is it kidney obstruction that's causing this pain? Is it kidney stones? Is it liver issues? I mean, there's all sorts. So that's why we have imaging to confirm or exclude whatever it is that you're trying to find. And so the renal scan also does something else. It tells me, has this kidney sustained any damage? And so it gets real complicated. So I just want to kind of give an overview. But even though you may have a long drainage time, but if the kidney function is normal, then that I don't really necessarily operate on those because you have to meet certain criteria for surgical intervention. One being, do you have pain? Two being, now this is assuming that reflux has already been ruled out with that catheter test. Number two, basically, pain is an indication, recurrent urinary tract infection, blood in the urine. And if you drink a lot of fluid and it causes pain, they have a special name for that. It's called Dietl's crisis, Dietyl apostrophe S crisis. And that's what I was referring to when you drink a lot of fluid and it can't get rid of all the kidneys trying to get rid of all the water, and then they suddenly have pain. Now, in children, especially in children, but adults too, the brain can't differentiate where the pain's coming from. And so the brain can interpret, oh, the pain may be coming from the belly pain. And, there's been six or seven that presented with children that presented to me because they were complaining of stomach pain. And so sometimes their physicians don't associate the stomach pain with a possibility of having kidney issues. And so in those kids, what I did was I ordered an ultrasound and I see like this just blown up renal pelvis, meaning that there's some sort of obstructive pathway that going or something going on. And then at that point, I will order confirmation tests. And then, so, we've come a long way with diagnosing the root cause of the hydronephrosis. So the hydronephrosis itself is not bad on its own. It has to be interpreted with clinical deterioration and or other forms of imaging. Otherwise, but I never operate just based on an ultrasound. I'm not saying you can't. That's just my practice pattern is if I'm going to do a major surgery, then I want to make sure that what I'm operating on is really what I'm operating on. Now, the topic of ureteral pelvic obstruction itself and ureteral reflux, those will each have its own episode because there's a lot of information. Today, really, in this episode, I just want to give an overview of, hydronephrosis because this is something that is actually very common. And so a lot of patients or friends, whatnot, have messaged me and asked, hey, can you do a video on hydronephrosis? And so, but now that you understand the kind of basic principle, then then when you see the hydronephrosis, then it'll make more sense on why your surgeon or doctor is ordering what they're ordering is really they're trying to confirm or exclude a diagnosis. And so now the other thing, and so back to the causes, right? So we have one, just to recap, reflux, meaning that the ureter is just not inserted deep enough into the bladder, so it clamps down. And so when they talk about this 5-to-1 ratio, meaning that the diameter of the ureter to the length of the ureter needs to be a 5-to-1, and that when the bladder contracts, it'll contract down on the ureter itself to prevent urine from coming back up. Second thing is ureteral pelvic obstruction. So the things I'm going through is the more common things because there are a lot of other stuff, and then also age wise. So the second thing would be ureteral pelvic obstruction. Is there a narrowing here due to a scar that was, there when the baby was born? And then as the kidneys get bigger, it makes more urine. And as it makes more urine, if this area does not open up in proportion to the amount of urine that's being made, so i.e., grow in proportion to that one kidney, then you're going to see an increase in hydronephrosis. Now, once let's say somebody comes in and they have hydronephrosis that I worry about, let's say the pelvis is 2 centimeter and I order a renal scan, but all I see is, the time for excretion is elevated. Let's just make up a number, 15 minutes. But the function is totally preserved and the patient has no clinical symptoms. Then those patients I would watch with a repeat ultrasound in 3 or 6 months. Now, there's no really protocol on how you follow patients with hydronephrosis. What we do know is that if you have hydronephrosis, typically you should follow them until about age 16 or so. The reason being is once the kidney has fully grown, then it's not going to make more urine. And so whatever narrowing here obviously has grown in proportion with the swelling. And so basically there's no more need for further imaging unless you have clinical symptoms. And what are clinical symptoms? Once again, back pain when you drink a lot of fluid or when you don't even drink a lot of fluid, urinary tract infection because of why? Stagnant urine. If you have stagnant urine, bacteria, so under H1, boys have a higher incidence of urinary tract infection than girls. Above H1, boys have a lower incidence of urinary tract infection than girls, and that has to do with the short urethra. So we have bacteria all around us, and no matter what we do, one day the bacteria will find its way up to the kidney. And that's where fever becomes important. So when parents come in for hydronephrosis, one of the things I always ask is one, does the patient have constipation? And that'll be another episode. But there's something called bowel bladder syndrome. And so when you have bowel bladder syndrome, it can cause your bladder to be dysfunctional, leading to recurrent urinary tract infection. Because why? Well, the bladder actually sits here, the rectum sits here, the nerve sits behind the bladder. So if you have chronic constipation, it can interfere with the way the nerves contract the bladder and open up the urethra. And so the urethra may be open when the bladder is not contracting, causing a way for the bacteria to go up into the bladder. And then eventually, now, if the popular thinking is that if there's no fever involved, then the bacteria must be contained in the bladder, because you have to keep in mind up to 40% of patients can have a urinary tract infection that does not require treatment, meaning that they may have like the burning sensation and all that, but they drink a lot of fluid. You can think of the bladder like a toilet. You're flushing it out. And so some patients will do that. And then but if the bacteria somehow finds its way up into the kidney, that's when the kidney will then elicit a fever response by sending out cytokines and all that. And so that's the reason why I always ask my patients, or if they can't answer, their parents, when they do have this urinary tract infection episode, is it just because of the burning, the foul odor, or is it because the patient actually had fever and pain in the back? Because infection of the kidney is painful. It's called pyelonephritis. And so that's where fever becomes very important. Now, what is considered fever? That's very debatable, right? And what I mean by that is it depends on what you're doing. So from an anesthesiologist standpoint, for instance, just from what my friends have told me, their cutoff for fever is 100.4. For us, surgical fever, I consider 101.5. But rarely will you get a urinary tract infection that is untreated that's going to come out to be less than 101.5. It's going to be 103, 104. They'll have chills, shakes, the usual, and it's not going to go away without antibiotic treatment. Okay. So, but like I said, because I don't want to make the episodes too long, because I do want to split up these diseases because I think they really do each deserve their own slot. So we'll talk about ureteral pelvic obstruction in a later episode. And I'll talk about vesicoureteral reflux in a later episode. Now, another thing that can cause you to have the same exact picture is something called ureteral, which ureteral just means ureter. Vesicle is just the medical term for bladder. So you can have ureteral vesicle obstruction. So what that means is the ureter inserts into the bladder, but the ureter is very narrow, and that causes the urine to back up. And so with those, typically you will see a dilated ureter as well as a dilated pelvis. Now that may not always be true, because when you have a little baby like that with bad hydronephrosis, the ureter may not be able to be seen. Okay. Now, another cause of hydronephrosis would be if the patient has something called duplication. And what that means is during development, we'll use this side. The kidney, they really don't have three kidneys, okay? They really still only have one kidney, but the top part of the kidney develop its own ureter. And usually the ureter to the top part will insert further than where the normal ureter would insert. And in females, it can actually insert after the muscular sphincter, which is what keeps females dry, right? And so if you have a 9 or a 10-year-old or an 8-year-old that has duplication and is potty trained but is constantly wet, that's one of the things you need to kind of keep in mind is, does that patient have a duplicated system? In males, they can have a duplicated system that also can insert into the urethra. The difference is in male, it always will insert before the sphincter. And so that's why in males with duplicated system with what we call an ectopic or abnormal insertion of the ureter, they will be dry because the sphincter is closing, and so that's why there's no urine that comes out. And so usually those kids will present either with pain, urinary tract infection, or whatnot. Okay, but so that's just a variant, and then now you'll also that's pretty much the major causes, and then now you're talking about unicorns now, and so one of the unicorn would be, and then when I say unicorn, what I'm referring to is they're not rare. So your top three or top four, which I didn't talk about the fourth one, would probably be due the hydronephrosis is due to ureteral pelvic obstruction, vesicoureteral reflux, ureteral vesical obstruction, or what we call idiopathic hydronephrosis. And that's what most patients are going to fall under, which is a good thing. Idiopathic just means that all the tests that we have available can't really find a source of why the kidney is swollen, quote unquote swollen, or but really the proper term should be hydronephrotic in the first place. And without more imaging, you won't be able to tell. And so once you do all the imaging, then you can't find a cause, then we label it as idiopathic. Now, maybe let's add a fifth one. So in older children, so in younger children who present with ureteral pelvic obstruction, then theirs is usually due to where the pelvis and the ureter actually meet. That area is just tight. And over time, as the kidney makes more urine, that area is just not opening up in proportion. And so you end up with, ureteral pelvic obstruction. Now, in older children who present with pain intermittently, then that's usually due to normally the kidney only has one blood or one artery that supplies it. However, sometimes in about 30% of the patients, they can have two ureter that supplies the kidney. And sometimes that one lower pole ureter can cause what you call a hook line effect. And what I mean by that is, if this is your ureter and you're draining, and you have a blood vessel that's crossing, it can kink the ureter, and so that's what we call a crossing vessel. And so with those, then surgery is probably going to be necessary. But the good news is, depending on how bad the hydronephrosis is, then you can. I usually give parents a percentage of what I think will need intervention at some point. However, the ones that we have done every single test on and we have found nothing is going to be idiopathic. So, meaning that at some point during development, there was an issue, but that issue no longer is clinically causing any issues. So, but the problem with hydronephrosis is just like a stretched pair of pants. Sometimes, if you overstretch it, it may not come back down all the way. But that doesn't mean that there's clinical deterioration of the kidney. And that's why it's important you follow with ultrasound. Now, there's no guideline on how often you do the ultrasound. So for me, I don't put patients in boxes. Basically, I tailor how often we do the ultrasound or confirmation test based on that patient, because every patient's going to be different, right? And then on my previous episode that I talked about circumcision, this is one of the few that I think a circumcision may be a good idea, because just to decrease the chance of getting a urinary tract infection. So if a circumcision is performed in the hospital within the first 30 days of life, that child will have, although not huge, but over the lifetime will have a decreased risk of uh, febrile urinary tract infection. Now, another thing that can happen, which is rare, is something called a polyp. So sometimes you can have a polyp that, just like in the colon, can grow in the kidney. And basically, that polyp can cause an obstruction itself. Another thing that can cause this is a stone. So stones don't cause pain. What causes pain is the stone gets lodged in the ureter and urine can't pass. And so it kind of basically pushes the urine back. So you get this back pressure. And that's where they have the severe pain. Now, I personally never had kidney stone, but that's why I have to try to keep myself hydrated. I don't want to feel it, but I heard it's worse than labor birth. And we won't talk about stone in this episode, okay? This episode really is just to go over the generality of what hydronephrosis is. And then another cause of hydronephrosis is basically if you have a dysfunctional bladder. So if you have constipation, it can interfere with the way the bladder functions, which then can lead to increased pressure, which then can lead to hydronephrosis. But usually with those, you will see the swelling on both sides. Now, usually when patients are not patients, but when the moms are pregnant, they usually do a pretty good screening with ultrasound. And that's where they find the hydronephrosis in the first place. The issue is when the baby's born, usually they will get an ultrasound 24 hours, 48 hours afterwards. The only problem with that is the kidney hasn't fully started functioning yet. And so if you get an ultrasound that's too early, you may miss a diagnosis. So typically what I do is usually about at around 14 days is when you will get a more accurate ultrasound. And so what I mean by that is now if they get an ultrasound in the hospital and the whole system is just all blown up, well, then probably need to do a confirmation test sooner than later. But the majority of hydronephrosis really will present with, kind of, I know I hate using it, but I don't want to use numbers on this one. Uh, if they present with like mild or moderate hydronephrosis on one side, they're doing okay, they're not having any infections or anything like that, then I don't recommend low dose antibiotics to keep the urine sterile. What I recommend is just to repeat an ultrasound in about 14 days. And then that'll really be your true baseline. And then from there, then I will figure out a schedule on how often do I get these ultrasound. Now, within the first year of life, the kidneys tend to grow pretty aggressively. And so I tend to follow pretty aggressively with ultrasound the first year of life. And then, kind of after that, then based on each patient, then I will then move them. So, this patient may need an ultrasound in 3 months versus this patient may need an ultrasound in 6 months. Now, this is given if there's no clinical symptoms. If you have clinical symptoms such as blood in the urine, urinary tract infection causing fever, or multiple urinary tract infection without fever, then I typically will order an ultrasound sooner. And so that's kind of a general overview of what hydronephrosis is. So hydronephrosis in and of itself is not necessarily clinically relevant. It only becomes relevant if it causes symptoms and or deterioration in the kidney function itself. And so and unfortunately, there's really no test that can really tell which patients will fall into the category that may need surgery and which patient will fall into the category of not needing surgery. Now, the Society of Fetal Urology, have come up with like kind of a chart that shows, if you're this grade, then you may, your chance of needing surgery will be as high as 50% or whatnot. For me, I really don't like to quote numbers uh, because all that's going to do is scare the parents and for no reason. So I always tell parents what matters most is what exactly is going on with your child, because with your child it's either 0 or 100, right? Now, if patient really want me to give them general statistics, I will, but generally patients or parents want to know what is their odds of their children or their child needing surgery. And that's really going to be based on what you find, meaning that you have to let whatever it is declare itself first. Once it declares itself, then by like let's say worsening of the hydronephrosis, then we will do confirmation tests. Okay, so hopefully that helps you better understand hydronephrosis. And so each one of those things that I mentioned in this video that causes the hydronephrosis, I will dedicate another episode to it because hydronephrosis is really an umbrella term that is, think of it like this, it's just the end result or the clinical manifestation of something that's going on. And what is that that's going on? Well, we have tests that can figure that out. But all of these tests are a little bit invasive, whether it be having to put a catheter in, having to put an IV in, and as far as even having to go back to the OR to really get a good delineation of what is kind of going on. And so, and then I'll leave you guys with this. There's really no studies that have linked the way you wipe to getting increased urinary tract infection. And definitely the odor does not correlate well with a positive urinary tract infection. So, just because you smell a odor that's different, because that can be from food or drink that that patient ate or drink, or whatnot. So you actually have to have, real clinical symptoms such as urinary tract infection symptoms coupled with fever, back pain that kind of supports infection of the kidneys. For me, it's a good idea to follow with imaging, especially something that's non invasive, and then order confirmation tests if required. Because for me, I always tell myself, if I'm going to order this invasive test, and this goes for surgery too, does the intervention outweigh the risk? Now, I know the risk of, putting in a catheter is low. You may get a urinary tract infection. I've seen it where the bladder was perfed, and renal scan, you have to put an IV in. And so ultrasound is very helpful in that sense. But ultrasound really just tells me kind of the clinical symptom on the inside that I can't see. And I use the images plus the history to determine what the next best route is. So I'll leave you guys with that. And then, um, the next episode will kind of delve deeper into each different etiology, how it's diagnosed, how it presents, and if surgery is warranted. And if it is, how is the surgery performed? All right. So this is Dr. Pham again with another exciting episode. Hope you guys love it. Subscribe. We're on all the major media platform. Show me some love so that basically I can keep doing this, and hopefully it'll help kind of educate patients. Like I said, you don't need to come see Crescent Urology for this. This is meant to be worldwide, right? So that you can ask your doctor the right question and then at least have a understanding, because I've seen it all where they go on Google and they type in hydronephrosis, and it's always, the bad, they always have the bad outcomes and all this. And then parents just get so nervous, and there's no need for that. And so that's my mission with these episodes, is to kind of educate the public on about urologic issues. All right. So I'll see you until next time. We'll figure out which episode, but please subscribe, and so that I can continue to do this. This is Dr. Pham signing off.
Like it's priceless, take it to the moon. Priceless, one day will be soon. Like it's priceless.